Good morning. I'm excited to talk to you today about fertility preservation along with Dr. Schirmer. I will be discussing this process for our male cancer survivors, and then he will be discussing this process for our female cancer survivors. I do not have any disclosures. The goals of this talk today are to recognize that cancer treatments can have an impact on our male gametes and their future fertility, to describe the available options for fertility preservation for men, and to identify barriers with respect to fertility preservation in male cancer survivors. The definition of fertility preservation is fairly straightforward. It refers to the process of saving or protecting sperm or reproductive tissues so that they can be used to father biological children in the future. Cancer touches the lives of so many young men. About 900,000 men are diagnosed with cancer every year, and over 75,000 are of prime reproductive age. We know that the loss of reproductive potential due to a cancer diagnosis or treatment for cancer is associated with severe psychological distress for our patients and really a drastic decrease in their quality of life. So preservation of fertility potential is an important part of cancer survivorship care and really should be part of our discussion with these patients prior to initiating cancer therapy. Guidelines from both ASCO and the American Society of Reproductive Medicine echo this concept. Interested patients should be referred to reproductive specialists, and we are fortunate at Emory to have an oncofertility program, a fertility preservation program, where we accommodate almost all patients that are sent to us within just a few days of referral. All available options for sperm cryopreservation should be offered to postpubertal men, and this is regardless of our concerns as providers about what sperm concentration or quality may be, or what the future health of that offspring may be. The goal here is to really empower our patients to make this decision themselves about fertility preservation for the future and to have no regret once they have completed their cancer treatment journey. I want to give a little overview of spermatogenesis in an effort to illustrate for you how cancer treatments can affect sperm production, both short term and long term. So, in the testes, there are populations of spermatogonial stem cells. They are really falling into two different categories. There's this category of dark spermatogonia and light spermatogonia. One population is there to regenerate itself and other cells, and the other population is there to really differentiate along the path of sperm production. The testis is highly susceptible to both radiation and chemotherapy at all stages of life. Although we tend to differentiate chemotherapeutic agents and now immunotherapeutic agents into sperm friendly and sperm toxic categories, there are really no sperm friendly cytotoxic agents. That's a message I give very clearly to my patients. And damage to the testicular germ cells can be permanent in many cases. The impact of cancer treatment on fertility preservation can lead to azoospermia, complete absence of sperm, oligospermia, drastic decrease in the concentration of sperm, poor quality sperm, just functional infertility, and besides fertility itself, ejaculatory dysfunction, as well as hypogonadism, so low testosterone in the long term. I have here an example of a list of chemotherapy agents. That these are the traditional agents. There are no immunotherapy agents on here, and how variable their impact can be in terms of the risk of permanent impairment of spermatogenesis. But really, so much of this depends on what the patient's baseline is at the time that they are starting cancer treatment. And often that is a baseline that we do not know unless these patients have already undergone fertility consultation prior to their cancer diagnosis. In terms of radiation therapy, the data is a little bit more clear cut, and the impact of radiation directly to the testis has a much more drastic effect on future spermatogenesis than chemotherapy does. If you are having exposure to the testis and to the gonads, whether that's the focus of the radiation field or that just ends up being a portion of the radiation field. Dosing of that radiation to the gonads is extremely important. Doses under 3 gray relatively are safer, but doses under over 3 gray are placing these patients at risk for permanent azoospermia. We also pay a lot of attention to the endocrine function of the testis because we know that radiation therapy can permanently damage Leydig cells, which are central in terms of testosterone production. And hypogonadism can result if there's gonadal exposure to greater than 20 grays of radiation in prepubertal patients and greater than 30 grays in postpubertal patients. Recovery of somatogenic function is very variable, and there are many factors that it depends on. Certainly the type of malignancy, the type of cytotoxic therapy that is chosen, and there's not a whole lot of data about the newer immunotherapy agents or the targeted therapies that are available for a variety of cancers now. But in general, we feel that the targeted therapies are safer than the traditional chemotherapies. We just don't have the numbers to share with the majority of our patients. So I give the same talk to our patients, regardless of whether they're getting a more traditional chemotherapy agent or if they're getting one of these targeted immunotherapies. A dose of treatment of whatever they're receiving is extremely important, as is the duration of treatment. We should also remember that patients may undergo one cycle of treatment. Some may go on to relapse, unfortunately, and require further treatment in the future, and that dosing then becomes cumulative in terms of their risk of future infertility. At a minimum, conception should be delayed for at least 18 months following completion of cytotoxic therapy. There's no strict guideline about this. Some physicians will quote a period as short as 6 months. Some physicians will quote a period as long as 48 months or 2 years. I usually tell patients, since one cycle of sperm production requires about 3 months for completion, to allow for at least 2 to 4 cycles, and longer is always better to wash out the effects of chemotherapy on sperm quality and sperm DNA. The patient's dilemma in terms of their treatment is always balancing their cancer therapy, the timing of that, and the initiation of that with future fertility potential. We know that there's tremendous interest in patients for fertility preservation. In this male survey of cancer survivors, 50% stated that they desired a child in the future. And among those who were childless at the time of their cancer diagnosis, over 75% expressed an interest in having a family in the future. But only 60% recalled being told about infertility as a potential consequence of cancer therapy. About half were offered banking, and only a quarter of them actually went on to bank sperm. Lack of information about fertility preservation was the most common reason for failing to bank sperm. And this is not to say that patients are not being told about fertility preservation, but it is also that in the tremendous amount of information that they're receiving regarding their cancer diagnosis and treatment, information about fertility preservation may be getting lost. So perhaps our communication around this also needs to change. In terms of using fertility preservation, we know that these rates are extremely low and variable across cancer centers. In this particular single center study, there were about 200 men who were planning to initiate chemotherapy. Only a third of them received fertility counseling, and only 11% attempted sperm banking. Those numbers are very, very low. And when the authors investigated what factors were associated with this, they found that older age and presence of comorbidities were associated with lower counseling rates around fertility preservation. So there may be some provider bias that creeps in there. And lower median income, and either a lack of health insurance or having Medicaid as their only health insurance coverage was also associated with a lower rate of banking. So there may be some bias there as well in terms of information and encouraging these patients to bank. Cost of fertility preservation is certainly a topic that comes up, and we'll be discussing that in a minute. Adherence to fertility preservation is an important thing to look out for in our patients. In this retrospective study from the UK, men were given three chances at banking prior to initiating cancer therapy. And here cost was actually not a factor. This was a coverage this was a service that was completely covered. And you can see that there's loss of patients between visit 1, visit 2, and visit 3. So that at the end, only about a third of these patients who started off in that initial cohort actually gave all 3 samples. Unfortunately, the patients who probably needed to bank most were the least likely to come back for visits 2 and 3. You can see that the folks that didn't come back for visits 2 and 3 started off with some of the lowest rates of sperm concentration and motility. And this again factors into how patients are counseled about the results of that first sample that they provide, and whether or not they are encouraged to provide a second sample, or whether they lose hope about providing a second sample because they are given this message that it will never work for them in the future, regardless of whether or not they bank additional samples. In terms of techniques for fertility preservation, on the male side, it's relatively easy. Dr. Schirmer will talk a little bit more about the female side where it gets more complicated. But on the male side, your easiest option is to have your patients provide an ejaculated semen sample. And I say it's relatively easy, but I also know that sometimes it is not possible. Our patients are so debilitated that they're actually unable to do so. So we do have some tools and some aids that can help us in this process, and I'll go through that one by one. If patients are unable to give a semen sample because of physical limitations, we can sometimes use penile vibratory stimulation. This is a tool that can be used by patients at home or in the clinic. It is extremely safe. It is easy. It is easy to purchase as well. These are commercially available. All patients have to do is really apply that to their penis to initiate the ejaculatory arc, provide a sample, and then that sample can be cryopreserved. Next option, if they're not able to engage in penile vibratory stimulation, or it's unsuccessful, or they have a separate injury, perhaps in their spermatic cord, that doesn't allow the ejaculatory arc to function, we also have this option of electroejaculation. Now, there's a caveat here. I say we have this option. We don't actually have it available at Emory. We do have it available in the city of Atlanta, and I have referred some patients out for this treatment. But this is a process which is a little bit more invasive, has to be done within a healthcare setting, but allows us to apply some current through the rectum that, again, engages the ejaculatory arc and reflex. The third option, which we have used here more commonly actually, is surgical sperm retrieval. So for patients who we think are producing sperm but are unable to provide an ejaculated sample through some means, we can do a small testicular biopsy and save testicular tissue, or we can aspirate a sample from the epididymis. The picture up top here shows you an example of epididymal aspiration. This is something that can be done in the office. And the picture below here shows you an example of a testicular biopsy. This is a more involved testicular biopsy example that we can sometimes do when we suspect sperm production rates to be very, very low, but a simple testis biopsy can also suffice in many cases. And then what happens with that sample once it's retrieved? So cryopreserved sperm can be used for a couple of different types of treatments depending on how they are retrieved and how many we have in terms of concentration and how well they are moving. If we have a good number of sperm that are fairly motile, and we can get to this threshold of at least 5 million motile sperm, that can be used for intrauterine insemination in the future. Some patients will also refer to this as artificial insemination. This is comparable to natural fertilization as far as what we do for patients as treatments. It is relatively cost effective. This is a process that is covered by most insurance plans, and it is of minimal risk to the female partner. Second option is in vitro fertilization. This is an option that we reserve for patients where we may not have 5 million total motile sperm. Either the concentration is low or the sperm are not motile. And this is a process by which we retrieve eggs from the female partner, sperm from the male partner, cause fertilization to occur in the lab, and then transfer one of those embryos back into the female partner. This is a process that is expensive, and insurance coverage for this process is variable. There are also some additional risks to the female partner because this process involves stimulation of egg production for the female partner as well as egg retrievals. The third process is something called ICSI, which is an option that we reserve for men who may have very, very low concentrations of sperm or very poor quality sperm, very low motility sperm. When sperm are not able to fertilize an egg on their own, we can actually physically inject a single sperm into a single egg and cause fertilization that way. This is a type of IVF technology, a little bit more advanced than standard IVF, and is also a little bit more expensive than standard IVF. Insurance coverage, again, varies between plans. This is important because how we obtain that initial sample can dictate how we use that sample in the future. Any type of ejaculated semen sample, whether it be through masturbation or electroejaculation or vibratory stimulation, can be used for IUI as well as IVF. But anytime samples are retrieved surgically, whether that comes from the epididymis or the testis, those samples have to be used for either IVF or ICSI to help with reproductive potential for the future. We know that sperm concentrations and sperm motility can vary greatly by cancer diagnosis. So in this study out of Utah, they looked at raw and post-thaw semen parameters in a large cohort of men, about 1,000 samples. And they looked at both cancer patients as well as controls. You can see on this left panel here, the difference in sperm motility, whether that came from the raw semen versus post-freeze semen. So when they thawed that out, what the sperm motility looked like. And you can see that the post-thaw parameters are always a little bit worse than the raw semen parameters. On the right panel here, you can look at total motile sperm count, which is what really matters to us in the end in terms of helping these patients conceive in the future. And again, in the raw semen, these parameters are on average a little bit higher than in the post-thawed semen. And I put this slide up only so we can counsel the patients about how many samples they should freeze. We always err on the side of freezing one extra sample or a couple extra samples because we know that when we go to thaw that sperm out, even though sperm freeze extraordinarily well, we will lose a proportion of that sperm in terms of concentration and motility. This slide is from the same paper. It actually shows this distribution in terms of how different concentrations can be based on the patient's cancer diagnosis. And testis cancer, which is the world of urology that I live in, these patients are at some of the highest risk in terms of impaired semen parameters at baseline when they come in for a fertility preservation consult. The use of cryopreserved sperm, there has actually not been a tremendous amount published on this topic, and the data is very variable depending on which institution you look at. Somewhere between 10 to 50% of men will come back to use their cryopreserved samples following cancer therapy. And we don't know whether this is because patients change their mind about having a future family or whether they end up conceiving naturally without the use of their cryopreserved sperm. But we know that pregnancy rates using that cryopreserved sperm, whether we end up using IUI or IVF or ICSI, are not significantly different from those rates in infertile couples that do not have a cancer diagnosis. So it does not, having a cancer diagnosis does not really change their ability to use that sperm in the future. And there are no additional congenital or developmental risks to offspring that have been identified after using cryopreserved sperm. So that's an important message for our patients. Insurance coverage for fertility preservation is really variable in the United States. Unfortunately, Georgia is not one of these states where coverage is mandated. So our patients end up paying for this service out of pocket. The cost for fertility preservation, depending on where patients bank and how long patients bank, varies somewhere between $200 to $400 per sample that's banked. And sometimes this has been used as a deterrent to encourage patients not to bank, not to invest in this, expecting them to have recovery of sperm production in the future. This is a study from one of our medical students, actually now a urology resident. But this looked at the cost of banking versus the cost of not banking for patients who have recovery of sperm production, and for then using that sperm that they have recovered for either natural pregnancy or fertility treatments in the future. And if you look at this cohort of testis cancer patients who undergo orchiectomy and chemotherapy, you can see that banking is overwhelmingly cost effective. Even if we look, 10 years out in terms of post-banking use of that cryopreserved specimen, there are very few cases where it would be not cost effective for patients to bank sperm, and that would really be if fertility treatments were extraordinarily expensive for them in the future. If you look at patients who have orchiectomy and radiation, I mean, really, there's no scenario where we wouldn't advise banking. And this is something that I share with most of my patients, to think in terms of the cumulative cost of fertility treatments in the future. Even if they are able to recover sperm production, that sperm may be very low in number and quality, and may require them to use more advanced treatments in terms of fertility, such as IVF or ICSI, when they could have gotten by with the use of something like insemination had they banked prior to cancer therapy. There's also good data telling us that establishing a formal oncofertility program results in better care for our patients. There is a tremendous increase in the number of patients who receive fertility preservation counseling. There's a tremendous increase in the number of patients who choose to undergo fertility preservation. And this is in the face of stable rates of cancer diagnoses, use of cryopreserved sperm, and discard of unused samples. We really ramped up our efforts in terms of offering our Emory patients fertility preservation a few years ago. And I know we have received several referrals from the community as well, for which we are thankful. I have my contact information on this slide, and I'm sure we can get that to you in other means as well. But we are happy to talk to any of your patients anytime. We usually try to accommodate them within a few days of referral. In summary, sperm cryopreservation is really the only reliable option to preserve fertility in males with cancer. Recovery of sperm production is possible in some men following cancer therapy, but this happens to variable degrees and in an unpredictable fashion. Use of cryopreserved sperm is safe, and it's not associated with increased risk of either obstetric or congenital complications. Thank you very much. I'm going to hand over the presentation now to Dr. Schirmer. Just give us a couple of minutes to allow him to share his screen here.
Thanks, Dr. Mehta. Okay, I'm going to just share my screen. Give me 1 second. Okay, and I think I've got the screen shared correctly here. Somebody please stop me if I don't. But thank you, Dr. Mehta, for that great review. And I'm going to go through fertility preservation in patients with cancer, focusing on female patients. So I have no financial disclosures to make. And in giving this talk, I wanted to review the impact of cancer treatments on ovarian function and fertility, to outline treatment options and timelines for patients who are about to begin for cancer treatment, and then to address common barriers that come up when approaching the topic of fertility preservation. So first of all, briefly, how does the ovary work? Normally, a woman is born with every egg she'll ever have. That's about 300,000 at the time of puberty, and then about 1,000 at the time of menopause. And Most eggs are actually not lost through ovulation. Most eggs are lost through atresia. So although one egg ovulates each month, hundreds or thousands go through atresia, essentially apoptosis, and are lost by that mechanism. Chemotherapy accelerates egg loss, and different chemotherapeutic regimens have different effects. Alkylating agents have the most profound effect. Heavy metals certainly can cause an issue as well. Radiation also damages ovarian reserve, but essentially what happens is in women undergoing gonadotoxic treatment, the number of eggs contained within the ovary is depleted, either to the point where somebody goes through premature menopause, or to the extent that they are at high risk of going through menopause within a few years of finishing cancer treatment. So even if their menstrual cycles resume, they may end up in a situation where menopause is just around the corner, whereas had they not undergone gonadotoxic therapy, they might have had menopause occur at a normal age. Average age is 50, normal distribution is 40 to about 60. And this is another way of showing, red here is accelerated, showing the accelerated decline in the number of follicles, the number of eggs contained within the ovary due to gonadotoxic treatment, compared with a normal group, which is not exposed to gonadotoxic treatment. A woman's risk of premature menopause or severe diminished ovarian reserve varies widely with the type of chemotherapy that's used. But anytime an alkylating agent is used, we certainly are very concerned about this. I would say that in general, it's better to err on the side of referring a patient for counseling about fertility preservation rather than strictly stratifying their risk and sending people who are presumed to be high risk, because any type of chemotherapeutic regimen runs the risk of damaging the ovaries, and there are many options for patients who may wish to preserve their fertility. Now, how does fertility preservation work? The take-home message here is that this can happen very rapidly. And if I wanted to emphasize one thing today, it's that this can happen very rapidly. Often patients and their physicians or care providers worry that if they refer their patient out for their female patient out for egg freezing, it's going to delay chemotherapy by weeks. It's going to take a long time to get them into the center. We'll have to wait for their period. It will take a long time doing this. And then by the time they come back, the cancer may have progressed, worsening their prognosis or necessitating additional treatments that wouldn't otherwise be needed, or both. And that's not the case. And so the way this works, if a patient's referred to us, we will very quickly on the first visit assess her ovarian reserve. When does that first visit happen? With our clinic, we try to make it happen overnight, literally, but if not, within a couple of days. So we will in our clinic be ready to receive a cancer patient. There is an order for those of us who use PowerChart to refer people for counseling. And once that order is placed, a message goes to our scheduling team. The scheduling team will call that day or the very next day, and they will find a spot. Even if we're booking out for months, they will find a spot on one of our schedules to add the patient on. We'll speak to the patient about the effects of chemotherapy on her fertility and her ovarian reserve. We will also speak to the patient about her fertility preservation options. And should she choose to undergo egg freezing, oocyte cryopreservation, or embryo cryopreservation, I'll talk about the difference in a minute, we will initiate this very, very quickly, often within a matter of a couple of days. And typically the treatment process takes about 2 weeks. Yes, that's a little bit of a delay, but with most chemotherapeutic regimens and most gonadotoxic therapies, we don't start treatment the day after diagnosis occurs. We have to have a port placed, we have to have an echocardiogram, we have to have lab testing done, have to get them an appointment at the infusion center. All of that usually takes the amount of time that it takes us to freeze eggs. So we very rarely cause any delay in starting chemotherapy or other treatment. The patient, from her perspective, will, after counseling, if she chooses to do this, undergo ovarian stimulation. So normally the ovary makes one follicle develop each month. We give injectable gonadotropins. And I'm going to talk about the impact of this on cancer in a minute, but we give injectable gonadotropins that she takes by herself 2 to 3 times a day, tiny insulin type needles, we tell them, so usually not very painful. It makes the ovary, I showed you that other ovary before, this is a normal ovary, and then this is an ovary on stimulation. So instead of making one follicle develop in a given month, we make as many as we can, hopefully 15, 20 more sometimes. We monitor her a lot. So she'll be coming in for vaginal ultrasound and blood work 5 or 6 times over 10 to 12 day periods. And we're very upfront about that when they come to see us. And then once her ovary has a sufficient number of mature size follicles, we will have her come in for an egg retrieval. She'll go to sleep. It's monitored anesthesia care, almost always with propofol. We'll place a vaginal ultrasound probe and we'll run a needle along the top of the probe through a needle guide through the vagina into the ovary. This looks very invasive, but it's actually an incredibly quick procedure, very, very low risk. And when the patient wakes up, most people have mild cramping and either need no pain medication, which is common, or sometimes some Tylenol. It's rare that people need anything more than that. Home usually within an hour and a half. Here's a close-up. What we're doing with this process is placing a needle into each follicle. The needle is used to aspirate the follicular fluid. Along with that comes the egg, which you can see here. And the egg is then taken to our lab where it is, usually cryopreserved for cancer patients in modern care. So most of the time we're going to cryopreserve eggs. It used to be very difficult to do this. Around 2013, this became non-experimental and standard treatment because of technology that allows us to freeze an egg, then have a very, very high rate of survival upon thaw. Some patients worry about the potential of their eggs. Is this egg going to survive the thaw? And also, how do I know if I have an egg that it's going to become an embryo? One egg gives us a 12% chance of live birth, which is why we try to get many eggs, so that we have a reasonably high likelihood of helping a patient conceive in the future. But some patients, especially patients in long-term committed relationships, will actually choose to freeze embryos. So we can fertilize eggs in our lab before we freeze them, grow them into the embryo stage. This is a blastocyst stage embryo ready for transfer, and cryopreserve the embryo. Again, extremely high rates of survival. And why might we choose one or the other? Embryo cryopreservation has a proven track record, probably the highest success rates. And generally speaking, if somebody's in a long-term committed relationship and they're willing to take on the additional cost of growing embryos, it gives us the peace of mind of knowing how many embryos we have, whereas the potential of a given egg is, again, not entirely clear. But for young women who are single or concerned about whether they are going to conceive with their current partner, or who have ethical concerns about embryo cryopreservation, egg freezing is a wonderful option. It works very, very well with a high rate of survival. Some of you may be wondering, well, what do we do with these gametes once they're frozen? If it's frozen eggs, we fertilize them, make embryos, and place the embryo in the uterus. If we already have an embryo, we just place the embryo in the uterus. But essentially, we give the patient estrogen and progesterone, or allow her natural cycle to do that in the future. And then we use a tiny transfer catheter. I didn't show a speculum here, but this is not surgery. This is an outpatient procedure with the patient awake. Guide a tiny plastic tube through her cervix into her uterus and release the embryo in her uterus. Not surgery, no anesthesia needed for an embryo transfer, very straightforward. Generally speaking, people say it feels like getting a pap smear. How likely is this to work? Essentially, again, on average, 6 to 8 frozen eggs will give us a sufficient number of embryos for one transfer. How likely are we to end up with a live birth? This number, actually, our most very recent data showed a higher chance. A little plug for Emory Reproductive Center, but we have some of the highest success rates for IVF in the country. However, what's most important is just counseling patients. What are the chances she'll have a baby if we put an embryo back in her uterus? This chart shows 60%, more recently it was 65%. I think probably the mean falls somewhere in between there. And then as you can see, age plays a big role in terms of chance of live birth per IVF cycle. What's very important to know, though, is the age at which an egg or embryo is frozen, not the age at which an embryo is transferred. So somebody at 42 might normally have a fairly low chance of live birth per transfer, but if we're using eggs that were frozen when she was 33, her chances are actually here, not here. This is one of the reasons social egg freezing has become very popular. What if the patient has a heritable genetic disease, like BRCA, for example? and she's worried, I don't know if I want to have children strictly because I don't want to pass this gene on to my children. If we have a single gene mutation like BRCA or some of the other oncologic, or the genes that we know are associated with cancer, we can do something called pre-implantation genetic testing. A laser is used, you can see here, this is the targeting reticle, and essentially a laser is used to incise the zona pellucida, which is the wall surrounding the embryo. And then 7 to 10 cells are taken from the embryo. This is what's called the inner cell mass in this blastocyst stage embryo. This is where the baby would come from. We're far away from there. We're taking cells that will eventually become the placenta from the portion of the embryo called the trophectoderm. The embryo doesn't miss these. All of the cells in the embryo are omnipotent at this point. Doesn't harm the embryo's chance of implantation at all. We can then use pre-implantation genetic testing to determine if the embryo is affected by the gene of concern or not. This can also be used for HLA typing, which can be useful for patients with, for example, a child with sickle cell disease who are trying to find a genetically matched donor. Now, we can also screen the embryo to see if it's aneuploid or not. And as a woman ages, this becomes more likely, but we can tell if an embryo has a normal number of chromosomes, normal copy number or not. Why might we want to do this? We've all heard of aneuploidy in the form of Down syndrome, for example, although that's actually fairly rare. Many aneuploid embryos never implant or become a miscarriage. We can use this technology to determine which embryos are most likely to result in a healthy live birth. So in terms of HLA matching, this is more applicable for example, a patient with sickle cell disease or somebody who's trying to find a child who's unaffected by a specific condition and might serve as a donor, a tissue donor to a sibling. It's possible to use pre-implantation genetic testing and for aneuploidy and for the disease of interest to find an embryo that's euploid and therefore most likely to result in live birth and then free of disease-causing mutation. I do tell patients to keep in mind that as we screen out embryos, we find embryos that are not eligible for transfer. It becomes increasingly likely that we may not have a normal embryo in a group of embryos. So this technology is not perfect. It's also expensive and there's a possibility of false positive or false negative, although that's fairly rare with modern technology. And in a study of people undergoing pre-implantation genetic testing to see if they had an embryo affected by a specific condition of concern, for example, BRCA, about 50% had 3 or fewer embryos available after they used their eggs to make embryos, and only 20% had only 1 embryo available to biopsy. So we do talk to patients about the limitations of these technologies up front, but for a patient whose biggest concern about the possibility of having children is the possibility of passing on a heritable cause of cancer, we can work to help her assuage those fears before she does an embryo transfer. As I mentioned before, one of the key drivers of age-related infertility is aneuploidy. So as a woman ages, the chance that an embryo is aneuploid, has abnormal chromosomes, increases. Should we still refer patients at any given age, upper 30s, early 40s? Absolutely. And we will have this conversation with them. We'll tell them that we can screen embryos for chromosomal aneuploidy before we put them back. This also makes a difference because one thing that we do sometimes see is patients being told, look, we're going to have you on some sort of suppressive therapy. For example, for breast cancer, you can't conceive for 5 years while you're on this. If the patient is here when they're told this, their prognosis may be significantly more or less positive when they finish their suppressive treatment regimen. So it's important to know that age-related fertility does matter, even if a patient's not receiving a treatment that's overtly gonatotoxic. If they're being told they need to wait many years before they should attempt conceiving, seeing us is usually a good idea because oocyte cryopreservation makes it so that we can store 34-year-old embryos before this big upswing occurs in their risk of aneuploidy, for example. What if it's too late? What if the patient had chemotherapy? What if she was 45 when she saw you and is concerned about her fertility and maybe chooses not to cryopreserve oocytes after she speaks with one of us about the chances that those oocytes would actually result in a viable embryo in the future, which is low. Up here, this is donor eggs. So we can use eggs from a younger woman, most often an anonymous egg donor, sometimes a directed donor, for example, the patient's sister who happens to be significantly younger than they are. And the chance of live birth per embryo transfer in a woman who uses a donor egg, assuming the donor is under 35, reflects that we would see if the donor herself underwent IVF, and it's very high, regardless of the patient's age. This green line is the patient's own eggs and chance of live birth per attempted IVF cycle. This is donor egg IVF, showing how well donor IVF works. What can we do to try to prevent premature menopause? Now, I'm going to step away from fertility preservation. I want to make this part really clear because it's not always that clear, and understandably so. Fertility preservation requires oocyte or embryo cryopreservation. But suppressive therapy, suppressing the woman's menstrual cycle, suppressing her HPO axis, may, in some cases, increase the likelihood that she'll resume spontaneous menstruation after, that her periods will come back. She will not be in chemotherapy-induced menopause. What I'm about to say, I want to make it clear, not fertility preservation therapy. And so one thing that we can do to try to improve the chance that women will not go into menopause, and there are medical benefits there, bone mineral density, cardiovascular disease, possibly neurocognitive benefits of not going into early menopause, is suppress her HPO axis using some sort of suppressive agent, usually a GnRH agonist like Depo-Lupron. There are others, of course. Why? Using this in advance of treatment, and this can be started pretty quickly, I will always talk to a patient about this, may limit blood flow to her ovaries, limit metabolic activity within the ovaries, and therefore somewhat mitigate the loss of eggs. Does this preserve fertility? It does not, that we can see. But in general, in terms of protection against loss of menstrual cycles, several studies have shown a difference. Others have not. So we tell patients it's far from a sure thing that giving you Lupron prior to or during your chemotherapy or both is going to make it so that your menstrual cycles come back. But it's something we can do with relatively little harm. Side effects of Lupron can be unpleasant, hot flashes, night sweats, sleep disturbances, mood changes, but most people tolerate it fairly well. But again, we always tell patients that this is a separate issue from egg freezing. This is to try to preserve the likelihood of menstrual cycles resuming. So I wanted to address common barriers to fertility preservation. Fertility preservation, first of all, may not be, or the counseling may not routinely be performed by physicians. About 30 to 60% of survivals don't recall having received information at the time of diagnosis or thereafter from their healthcare team about risks of cancer treatment. And they are more likely to recall that these discussions happened once fertility treatment had begun. Of course, we know this may be changing rapidly over time as this becomes, their awareness of this increases. We also know, of course, recall is not perfect, but it is important to make sure patients are counseled about this. Whether they choose to see somebody like me or not, it's up to them, but counseling is important. Some patients are worried about the risk that their cancer is going to recur after having a child, certainly reasonable, but fertility preservation in advance at least keeps the option open, and then a decision can be made farther from the time of diagnosis when more about her cancer and her response to therapy is known. They can be worried about cancer risk in children. And again, not every cancer by any means, most of them are not, has a heritable cause. But if we have a single gene mutation that we know about, we can tell patients that we can screen for it in the embryo if they are very worried about this. And concerns about a delay in treatment, again, we work with you to make sure this happens very rapidly and is not an impediment to safe, rapid, and effective cancer treatment. Access to a fertility center, less of a concern locally here in Atlanta, but certainly a big concern for our patients out across Georgia and across the region who don't have ready access to a fertility center. We will work with them. I mentioned that patients have to come for 5 or 6 vaginal ultrasounds and lab draws. We will try to find, even if they're doing their fertility preservation at Emory, a local facility, often a fertility clinic, but in some cases an OBGYN's office, where they can have their monitoring performed without having to drive 2 or 4 hours round trip to come see us. Cost of fertility treatment is an issue, which I'll mention in a second. And patients may not be prepared to think about this, but again, it's important to bring it up. We've actually recently managed to reduce the cost of egg freezing. So we have a discount now where we charge essentially our cost, I believe, which is around $4,000 per cycle. Medications can be expensive, but in many cases, patients qualify for free medications through a program, a couple of programs that are run by Walgreens and Livestrong. And there are some charitable organizations out there that help reimburse the cost of treatment. These programs are actually fairly liberal with respect to who they are willing to give coverage to. So it's not only people with very low income. They, generally speaking, are quite accepting of most patients in these programs. Depo-Lupron can be somewhat expensive depending on the patient's insurance and the formulation used. Generally, we've seen when this is ordered through the infusion center, coverage is better, and we do talk to our colleagues in oncology about that. Embryo freezing around $11,000, so it's much more expensive to make embryos than it is to freeze eggs. Egg donor IVF can be $25,000 to $35,000 when we are paying the donor for her time and her services, depending on the type of donor that's used. And if a patient can't carry or does not want to carry on her own, gestational carriers can be used, but they are very expensive because the cost of obstetric care, the cost of reimbursement is high. Does this process impact survival? A lot of patients and sometimes doctors worry, my patient has an estrogen or progesterone or both receptor positive breast cancer. I don't want to put her at risk of recurrence that wouldn't otherwise have occurred. We don't see an decrease in relapse-free survival that's significant in either patients who are treated with without or just with regular egg freezing ovarian stimulation regimens, but we certainly don't see any effect in patients who are treated with letrozole, which is medication that will lower her estrogen level. It's an aromatase inhibitor that will keep her estrogen level very low, on par with what she'd experience during a normal menstrual cycle. So we're very cognizant of this issue. We explain that this is an extremely safe procedure to go through without an increased risk of cancer recurrence, but we're going to give her medicine to keep her estrogen level low in order to prevent any residual risk from affecting her. And so in general, many options exist. Fertility preservation counseling is an essential part of comprehensive cancer care. We are happy to help your patient determine the need for freezing of eggs and the best technique. And for women undergoing chemotherapy, freezing eggs or embryos is the best option for future childbearing. So again, we are always happy to see patients very, very rapidly. We can be reached here. There's also a referral order and power chart now for egg freezing. Thank you. We'd be happy to take any questions in the Q&A box. Okay, thank you for your attention.
Thank you.